So there has been some clinical trial data that has suggested that renal artery denervation may have an antiarrhythmic effect. It's been shown previously in work that we've done in a small pilot study relative to decreasing the likelihood of atrial fibrillation recurrence after ablation when renal denervation was added to the procedure. But it was a pilot study and it had an insufficient sample size to be definitive. The ERADICATE AF trial was designed to overcome the limitations of a small clinical trial and to provide more definitive data in a large-scale, multi-center, randomized clinical trial. ERADICATE AF was designed to test the hypothesis that renal artery denervation, in addition to pulmonary vein isolation, the standard technique for ablation of atrial fibrillation, adds incremental value and is done so in a safe way. The trial enrolled about 300 patients and randomized them 1-to-1 to receive either pulmonary vein isolation alone or pulmonary vein isolation with renal denervation. So at HRS 2019, we presented the primary endpoint data of the ERADICATE AF trial. Enrollment was completed earlier this year, which gave us the opportunity to present the first pass of data analysis. And specifically, we presented the intra-procedural results and the primary outcome. The intra-procedural results indicated that when renal denervation was added to pulmonary vein isolation, there was no increased risk of the procedure, and the complication rates were identical and small. We also saw no long-term detrimental effects of renal denervation. The primary endpoint of the study was AF freedom at 12 months off antiarrhythmic drug. We found that the patients who underwent renal denervation with pulmonary vein isolation had an AF freedom frequency of 72.1%, which was substantially higher than the control group of pulmonary vein isolation alone, where the AF freedom rate was 56.5%. In other words, there was a 43% reduction in the likelihood of AF recurrence after a catheter ablation procedure. Given that we have now shown in our studies, as well as multiple studies using renal denervation for treatment of hypertension, that the procedure can be performed safely. That was the first implication. And we've now expanded the potential value of renal denervation beyond the hypertension universe. We've now demonstrated, I think, fairly clear-cut evidence that there is the potential for antiarrhythmic efficacy in patients who have both AF and hypertension. And it is reasonable to look at the inclusion criteria of this trial, which specifically included paroxysmal AF patients referred for ablation and a history of hypertension, but not necessarily high levels of hypertension. And those patients responded to the renal denervation procedure. What is uncertain is, did they respond entirely because we achieved better blood pressure control, which we did, or did they respond because of a specific antiarrhythmic effect of renal denervation, which we would hypothesize would be a reduction in central sympathetic tone. In the future, we will test that hypothesis further by potentially applying a randomized clinical trial to test this technique in patients who do not have a history of hypertension. The current implications, the practical implications, are that it may be time to start applying renal denervation to patients who meet this clinical trial criteria in our current day practices.